Hi guys, so a lot has been going on the news recently about how the transmission rates of HIV are actually increasing, especially among adolescents. That's why actually someone approached me and actually asked me to do a video on pre-exposure prophylaxis and post-exposure prophylaxis in relation to HIV. And I really thought it was a good idea. So grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at pre-exposure prophylaxis as well as post-exposure prophylaxis with relation to HIV. So remember that everyone that has significant risk of getting HIV must be placed on pre-exposure prophylaxis. That's the first recommendation. Secondly, we use antiretroviral drugs. The same drugs that we use to treat HIV are the same drugs that we actually use to actually prevent HIV infections in those individuals that are at risk. So it actually is used for the PrEP and the PEP. PrEP is pre-exposure prophylaxis. PEP is post-exposure prophylaxis. And the third recommendation is that adherence and treatment support actually should be given to all patients that are on PrEP. It should be given to all patients that are on PEP. And of course, PrEP should be offered to all patients that are HIV negative, whether they are breastfeeding, whether they are pregnant, in serodiscordant relationships. What do I mean by serodiscordant relationship? A situation where the mother is HIV negative, but the husband is HIV positive, and they are at substantial risk of getting HIV. Now we'll start by talking about pre-exposure prophylaxis, which is PrEP. So this is just basically giving medication or antiretroviral drugs to those that are at high risk of getting the HIV infection. So when someone is exposed to HIV through sexual contact or even through injected drug use, or even sometimes through sharing of needles, blood and blood products, then we pretty much want to give drugs, the antiretroviral drugs, which are pretty much going to be preventing the virus from actually establishing a permanent infection. Because remember, if you look at the life cycle of the HIV virus, it replicates using your reverse transcriptase, and then eventually it's going to be forming DNA. Itself is an RNA virus, but it's going to be forming DNA, which embeds into the host genome. So before it actually embeds into the host genome and it remains as a permanent infection, we want to prevent this by giving pre-exposure prophylaxis. It's like wearing a raincoat before you actually go out in the rain. So with strict adherence, the efficacy of this is actually very, very high. Now, the drugs that we use include tenofovir disoproxil fumarate, which is TDF, for those that cannot remember this long name, and then tenofovir alafenamide, which is a TAF or TAF. I'll explain why we have two preparations for TDF and TAF very shortly. Then, of course, you can either use emtricitabine, which is FTC, or lamivudine, which is 3TC. A combination of the two. This is, if you see the abbreviation XTC, what I simply mean is either emtricitabine or lamivudine. So these are the drugs that we use for pre-exposure prophylaxis. Now, remember that you have two preparations of tenofovir. You have the TDF and you have the TAF. Now, you can either use TDF or TAF combined with XTC, which is either emtricitabine or lamivudine. And remember that these agents are going to be active even against hepatitis B, because the enzyme that is actually needed for proliferation of the hepatitis B in the life cycle has some reverse transcriptase activity. So these drugs can also work against hepatitis B. So on patients that are actually on this regimen, you should actually monitor them for rebound viremia in terms of hepatitis B. And TDF must actually be avoided in certain scenarios. It must be actually avoided in individuals that have renal insufficiency. It must be avoided in these individuals that have a creatinine clearance of about 30 to 50 mils per minute. So instead, you want to use a combination of the TAF, the TAF, combined with your emtricitabine. Then, of course, do not use TAF in patients that are receiving rifampicin. Do not use it in patients that are pregnant. And then, of course, avoid using TAF in patients that have osteopenia, osteomalacia, osteoporosis. Instead, you should use TDF because this has less of the bone loss that may actually worsen the underlying condition that they may have. Remember that the fact that we avoid these drugs, TDF, in patients that have renal insufficiency means that it has some renal toxicity. So do not combine it with drugs that are nephrotoxic like aminoglycosides. And make sure that you're monitoring this patient's creatinine clearance and their creatinine values over regular intervals. I'll give you a slide of how you should actually monitor these. Then, of course, there is no standard interaction between the standard TB medication and, of course, the PrEP drugs. The only thing that you need to take note is avoid TAF in patients that are taking rifampicin and are being treated for TB. Then, of course, there is no interaction between your standard hormonal contraceptions with the drugs that we give in PrEP. Then, of course, all patients, before you actually start them on PrEP, it is very important that you test them for HIV, because you don't want to treat HIV with 2 drugs. You want to treat it with 3 drugs. And if they are found positive, then you should switch them and you now start treating them for HIV. Now, the most important thing that people don't get, even if you wear a raincoat, it doesn't guarantee you that you're not going to get wet. But of course, the essential parts will be covered, and there's a big chance that if you get a raincoat and an umbrella, there's a big chance that you won't get wet, you won't get soaked. Now, there is also a chance that you will get soaked, especially if the rain is quite heavy. Same thing, these drugs are not 100% effective at preventing HIV transmission. You have to use other methods as well. So in a patient who's taking PrEP and they're at risk, you would advise them, at least when you're having sexual relations, use a condom in addition to you taking this medication. Yes, the PrEP is going to be quite effective, but it's not 100% effective. So use additional methods to prevent the contraction of HIV. Then, of course, when it comes to pregnant women and breastfeeding women, remember that all women that are pregnant, all women that are breastfeeding, that have contracted HIV at this particular time are at actually much greater risk of transmitting the infection to their infant compared to those that were that got the HIV infection before they even became pregnant. And the drugs that we actually use for PrEP are safe for pregnancy as well as for mothers that are breastfeeding, those that are HIV negative and are at risk of getting HIV. Then, of course, all patients that are breastfeeding, all clients that are pregnant should be screened for the side effects, and they should also be screened for HIV. Now, what are the indications of actually starting someone on PrEP, especially if they're pregnant and they're breastfeeding? So, number one, if a woman is having significant risk of getting HIV, that's the single most thing that's important. If they're at risk of getting HIV, then you should put them on PrEP. Number two, if the pregnant woman or the breastfeeding HIV negative woman perceives herself to be at substantial risk of getting HIV, you should put them. Prevention is always better than cure. Then number three, if the pregnant woman or the breastfeeding woman who's HIV negative and the partner is HIV positive, emphasis on the woman being HIV negative. You don't want to start PrEP on someone who's positive. It's like getting an umbrella but you're already soaked. It doesn't make any difference. Then, of course, an HIV negative woman who's trying to conceive with an HIV positive partner, you want to start her on PrEP before she actually gets pregnant and before she actually tries to conceive. Then remember that PrEP is not for everyone. All clients that are actually starting to take PrEP must be educated on PrEP. So they must be told that this is not a 100% fix. It's not a bulletproof vest. You still are at risk of getting HIV. That's the first thing that you need to understand. Number two, these drugs should be taken as long as this woman is at risk. They should be taken the way they are prescribed. Adherence is very important. Number 3, there are some side effects that this woman may experience. So you explain all these things and you give the woman the benefits as well as the side effects of these drugs, and then let her choose whether she wants to take it or not. No one should be forced. It's not mandated that you should force people that are at risk of getting HIV to actually get the pre-exposure prophylaxis. They must make their choice. But all individuals that are to be started on PrEP must first be screened for active infection. They must be screened for HIV. Make sure that you test them for HIV. You get a proper history, a proper physical examination, and you rule out HIV. You do not want to start someone who's HIV positive just on 2 drugs. Then, of course, what's our eligibility criteria? If there's no suspicion of acute HIV infection, if the woman has tested HIV negative at the health facility, make sure you test her. Then, of course, if she perceives that there is a substantial risk, or if there is an evident substantial risk and this woman is willing to adhere, if they're able to actually regularly test every 3 months, and they should test for HIV and should have these reviews every 3 months, then, of course, if they're able to actually use other preventive methods such as barrier methods to prevent the transmission of sexually transmitted infections, because the antiretroviral drugs are not going to protect you from getting gonorrhea. They're not going to protect you from getting syphilis. And of course, if the woman is willing to stop, or the person is willing to stop taking the PrEP whenever they are no longer eligible, or if they do become HIV positive, they are willing to transition to actually start the HIV treatment. So the woman or the individual must tick all these boxes. Once they tick all these boxes, then there are some substantial risk assessments that we want to carry out. So those that are at substantial risk are those that are going to be engaging in one or more of the following things within the past 6 months. So if they've had any vaginal or anal intercourse without condoms with more than one partner, if they are sexually active with a partner who is known to be HIV positive, or even those that are at substantial risk of being HIV positive, for example, sleeping with a prostitute. Number 3, if there is sexual activity with an HIV positive partner who is not on effective treatment. What do I mean for not on effective treatment? Someone should have been on treatment at least more than 6 months. So if they have not been taking treatment for more than 6 months, or they are not virally suppressed, then they are putting you at risk of getting HIV. Then, of course, if there's a history of sexually transmitted infections, if there's a history of post-exposure prophylaxis use, then, of course, if there's a sharing of injection materials or even equipment. Now, what are the recommendations for actually PrEP? Remember that for it to be effective, it needs at least 7 days in men and at least 21 days in women. Remember that the transmission dynamics are not the same. It's not the same for a male to contract HIV from a female than it is from a female to contract HIV from a male. Then, of course, number 2, repeat the HIV test at 1 month when you start them on PrEP, and every 3 months when the client is on PrEP. Frequent HIV testing during the PrEP period should actually be used. Ideally, this should become an opportunity to screen for STIs and also manage the STIs if they are STIs. And if the patient actually seroconverts and they become HIV positive, they should be switched to the first-line HIV drugs. And of course, we should provide this as a package, not only just giving the PrEP and say, go ye therefore and do some nasty business. No. You must also offer them other things as a whole combination prevention package, things like condom use, family planning, STI screening, so on and so forth. Now, the test that we do before this patient is actually started on PrEP, we do an HIV test. So only HIV negative partners are started on PrEP. Number 2, we do our creatinine, or at least urinalysis if creatinine is not available. We check our liver enzymes, especially ALT. We do a syphilis test, your RPR, and of course you screen for hepatitis, because those that are positive for hepatitis more or less will be on lifelong treatment of TDF plus XTC, which is emtricitabine or lamivudine, to treat the hepatitis B virus. Then of course, lab monitoring while the patient is on PrEP. So we do creatinine at 1 month, 2 months, and then every 3 months for the first 12 months. Then after that we do it yearly. Then of course we do ALT every 3 months for the first 12 months, and we do it annually afterwards. Then we repeat the HIV testing for the first month, or before they actually start the PrEP. Then we do it every 3 months. Then of course it's necessary to perform these lab tests as per indication. For example, someone presents to you with liver symptoms, do lab tests that are oriented towards liver disease. Then of course you should do a pregnancy test, because especially if they're on a regimen that has a TAF, we want to avoid that in pregnancy. Then here is just a schematic, a table rather, where there's an activity on the left side and the time of the visit. So confirmation of HIV negative status, you should do this initially at 1 month and then every 3 months. Then of course adherence counseling should be done every single visit. Side effects should be talked about on every single visit. The creatinine clearance test should be done initially the first month, the second month, and then every 3 months for the first year, and then you do it annually. Then of course ALT must be done every 3 months for the first year, then annually. Then of course STI screening must be done every visit. Then of course the PrEP drug dispensation, giving out these drugs must be done on the initial visit. It must be done the first month and every 3 months. Then of course the behavioral sexual risk reduction counseling must be done with every visit. Then of course there is adherence and support on patients that are on PrEP. So remember that this should include the information with regards to the PrEP, and that it is highly effective only when it is strictly adhered to. And remember that there is a duration of it becoming maximally effective. In men it's roughly around 7 days, in women it's about 21 days. As long as they're taking the drugs effectively how they should, this will protect them after 7 days in men, 21 days in women. Then of course it should be like a client-centered counseling that links the daily medication use to certain habits. Like for example, every time you wake up you take the drug, when you're going to bed you take the drug, or during a certain meal, that's when you take the drug. This can help with adherence and compliancy. Then of course special programs can be used to facilitate adherence in particular group, like for example in young people or in women. There are some different groups even on social media, on Facebook, that may help peer-to-peer sharing of experiences and even challenges on patients that are actually taking PrEP. Then of course people should start the PrEP and report any side effects that they have actually experienced in the first week or any time during them taking the PrEP. So these side effects include things like nausea, abdominal cramping, headaches, and typically it's mild and self-limiting and doesn't require discontinuation of the PrEP. So this must actually be advised to all the patients that are starting on PrEP, that you may experience this startup syndrome, and this should lead them to continue taking the drug as long as they're at risk, and they shouldn't stop. Now you'd ask me, when do you stop taking the PrEP? So the PrEP can actually be discontinued if a person has been taking it and is no longer at risk, and when the situation is likely to be sustained. For example, they are no longer engaging in any risky behavior or anything that has been defined before, or any indication that may have led them to start taking the PrEP. Then of course the PrEP should be discontinued after 4 weeks of elimination of the risky exposure. Then significant side effects, or even if the creatinine clearance decreases to less than 50, then especially for recipients that are taking TDF based PrEP regimens, they should actually discontinue. Then of course if they're in a serodiscordant relationship, then the HIV positive partner has been on antiretroviral therapy for more than 6 months, or is known to be virally suppressed, and there is no other partner, then the HIV negative partner can actually discontinue PrEP, because the risk of transmission is almost low, it's almost negligent, although there is still a risk of transmission, but it's lower. Then of course for pregnant women and breastfeeding women, PrEP should be continued. Here's a schematic to help us understand everything that we've been talking about. So you first get a patient that wants to start on PrEP. Then of course we use the rapid tests as per guidelines. We'll talk about HIV in another video. So if they are positive, then we start them on treatment as per guidelines. We screen them for TB, we screen them for STIs, and of course if they are negative, then we screen for potential eligibility for the PrEP. So we screen for the risk assessment, we do a risk assessment. Then of course if they are eligible, then we actually want to do certain screening. So we screen for any pregnancy, we screen for hepatitis B, we do a creatinine or at least a urinalysis. Then of course on the same day we can actually start them on the PrEP. Then we provide 1 month prescription such that they come back after 1 month. Then of course we continuously provide them with a PrEP education as well as counseling. Then we book them for an appointment within 28 days and repeat the HIV test. Then of course if the creatinine clearance results is less than 50, then we contact the client to stop the PrEP and then to return and repeat the creatinine clearance test within 2 weeks. Then what about post-exposure prophylaxis? This is before now you are at risk. You're going to do some risky behavior, then you get the medication, then you go wear the raincoat before you go play out in the rain. Now suppose someone accidentally pushes you out of the house into the rain and you've been exposed to the rain. What do? This is known as a post-exposure prophylaxis. So this post-exposure prophylaxis is where we use the drugs to actually prevent HIV transmission. Now, there are two types. There's occupational related and non-occupational related. So non-occupational related in children especially is usually due to sexual abuse. In adults, we usually attribute it to occupational injuries like needle stick pricks. For example, you're injecting someone in the hospital, then they fidget around and then you end up pricking yourself with the needle having blood on it. And of course, the risk of acquiring HIV infection with occupational exposure is actually low depending on certain circumstances. Number one, if the patient is virally suppressed, it's going to be a low risk. Number two, depending on the extent of the exposure. For example, it's 1 in 3,000 cases after you have percutaneous exposure, and it's about less than 1 in 1,000, or not even 3,000, 300, 1,000 after mucocutaneous exposure. So there's no risk of transmission when the skin is intact. When the skin hasn't been breached, absolutely no risk of transmission. And of course, the factors that are associated with an increased risk of transmission include things like a deep injury, visible blood on the device that has caused the injury. Then, of course, if the injury is caused by a large bore needle and it's in an artery or a vein, and then, of course, if the patient is not virally suppressed, body fluids and even materials that pose a high risk of transmission include things like amniotic fluids, CSF, human breast milk, pericardial fluid, peritoneal fluid, pleural fluid, even saliva in association with the dentistry. You may also have synovial fluid, unfixed human tissues, organs, vaginal secretions, semen, and other visible blood-stained fluids and fluids from burns and even other skin lesions. Then, of course, other blood-borne infections like hepatitis B and hepatitis C. And remember that these things can actually even worsen the patient's situation. Now, what do you do when you're actually exposed at the job to an infectious substance? So immediately you must clean the site, wash it with soap and running water. Do not squeeze anything. Do not cut yourself again. Allow yourself to freely bleed. Okay? Do not squeeze, do not block anything. Allow it to freely bleed. And of course, if the exposed area is in the eye or a mucous membrane, flush it with large amounts of clean water. Do not use bleach. Do not use any caustic agents. Do not use any disinfectants. Then immediately contact your in charge or your supervisor. Contact a clinical officer or medical officer who deals with patients or who's going to determine the need for post-exposure prophylaxis and the need or the risks or the benefits of you starting taking the treatment, the post-exposure prophylactic regimen. Now, these are the drugs that are given and according to the risk assessment. So if there is no risk, for example, intact skin, we don't recommend that we start them on any drugs. If there is a medium risk, meaning invasive injury or no blood visible in the needle, if there is a high risk where there is a large volume of blood or fluid that has been come into contact, or a known HIV positive patient, a large bore needle, or even a deep extensive injury, or even if it's a penetrative sexual abuse, then we start them on the post-exposure prophylaxis. Here, the difference between this and the difference between pre-exposure prophylaxis is here we actually use 3 drugs. We're going to be using TDF or TAF. Remember, the same considerations are going to be used here based on creatinine clearance, whether they're taking rifampicin or whether they're pregnant. So you can use either TDF or TAF combined with your XTC, which is either lamivudine or emtricitabine, or you can use dolutegravir. You may use lopinavir, boosted lopinavir, atazanavir, or so on and so forth. Or alternatively, you may use zidovudine with your lamivudine plus boosted lopinavir in children that are less than 20 kg. Then in those that are greater than 20 kg, we use dolutegravir instead. Then of course, in those that are greater than 25, TAF, your emtricitabine as well as dolutegravir, and this should be given for 28 days. So the clients that are on PEP should have a test done before they actually start PrEP, because there's no point if you're starting PrEP and then the patient is already HIV positive. If they're HIV positive and discovered then they started on treatment, then you do the test 6 weeks after, then you do the test at 3 months. Then whilst they're on PEP, they should be reviewed, they should be offered appropriate laboratory investigations depending on the relevant situation. Then of course, management of non-occupational exposures, for example, if those who have been sexually abused at home. So the non-occupational post-exposure prophylaxis is a provision of these antiretroviral therapy to individuals that have been put at significant risk, especially within 72 hours. So these individuals should be given these drugs if they have been sexually assaulted, for example, where you're not really so sure about the HIV status of the assailant, or in circumstances where there's significant exposure to HIV contaminated fluids, or if the patient just comes in with a non-occupational related post-exposure prophylactic request, and they should be evaluated for any substantial risk behavior for HIV acquisition. And of course, those that are at substantial risk or repetitive requests for these non-occupational post-exposure prophylaxis must be cancelled for PrEP, so they could be eligible for actually taking PrEP. And of course, remember that the drugs for the occupational related post-exposure prophylaxis is the same as the non-occupational related, the ones that I just discussed earlier on. So here's a schematic about post-exposure prophylaxis. So if there's substantial risk, less than 22 hours since the exposure, then of course the source of the patient is known to be HIV positive, or you don't know the status, we want to start them on non-occupational post-exposure prophylaxis. If it's more than 72 hours, we determine it case by case. There are different scenarios where we do start them, there are different scenarios where we don't. If there's no risk of exposure, then there's no need for you to actually start them on PrEP. And of course, here are certain body fluids that actually pose an individual to be at substantial risk. We already talked about this. And those that have negligible risk, or even close to zero. We never really say never in science, and we never really say always. I really hope you enjoyed this lecture on PrEP and PEP. If you did, please consider dropping a like, consider dropping a comment in the section below, subscribe to the channel if you haven't. My name is Dr. Moses Kazevu. Until next time, bye-bye.